Okay, sorry for everybody who was just live and got dumped because I don't know what happened. If my connection went bust or what. Cat back on, and hopefully we won't all get bailed. I don't know what happened.
I know, what a bummer.
Okay.
Okay.
Well, we're back. I guess we should get to the important stuff. We were going to talk about breast implant illness tonight.
Yeah, let's cut to it. What do you see a lot of women who complain of symptoms of breast implant illness?
I don't see a ton here, but we have one of the docs who's really active in the breast implant illness sites, Dr. Jean Feng. Her clinic is in Pepper Pike, which is right near us. So I think many of them go her way, but I do see the occasional one. And I know we have some colleagues who really have spent a lot of time investigating and learning about this, like Dr. McGuire in St. Louis. Do you see a lot out your way?
I do actually. There's a fair amount of patients, and I think Dr. Fang fills a need or niche in that a lot of women are seeking other women for explant surgery. So Dr. McGuire in St. Louis is does a lot of them. Dr. Lawrence, Marissa Lawrence in Atlanta,
Yeah.
and Souter in, I think she's in Seattle or in that upper corner of the country on the west somewhere. She does a ton too. And, you know, we all collaborate and talk about, we had a discussion about it at our retreat too, presentation on explant. So, you know, for surgeons, our focus is usually on the best way to remove the implants.
Right.
But for the women, it's mostly about what are you having and whether or not that could be caused by, or your breast implants could be contributing to it.
Right. And that's the hard part because it's just not very well characterized. And certainly the medical field is making an effort to improve like our diagnostic criteria for that. Right now, there really aren't any. And the symptoms are very wide ranging and have a lot of overlap with autoimmune disorders like rheumatoid arthritis or lupus. So what are the main complaints that you see with your patients?
So it's most commonly fatigue, some memory loss, and then I have a fair amount that have like a rash, an undiagnosed rash, or some sort of kind of allergic reaction that they can't get rid of, or they can't seem to get to the bottom of. And you know, they've usually seen a few of their either specialists or primary care. And like you said, because there's no diagnostic testing specifically for that, they're just ruling out, you know, some of the other things, some of the rheumatoid arthritis, some autoimmune disorders, and then saying, you know, none of this is popping positive. We don't know why you're, you know, feeling this way.
Right.
Yeah, so that can be tough. Some of them have gone through great lengths to, you know, do dietary and supplementation and other things to try to feel better. And
It's tough. Those
yeah.
kind of symptoms are so generalized to so many different things. And with implants, you know, they're one of the most studied devices on the market. They have been studied by the FDA to a great extent. And we know that they're not dangerous, but it's still a foreign body and your immune system can react. We just don't know who's more likely to have that or how to diagnose it so that we can predict whose symptoms are going to improve after removing implants.
Yeah, I think that's the crux of it. It's not you know, the overwhelming majority of women will be fine with their breast implants, just like the overwhelming majority of my patients are okay with, you know, paper tape on their incision or
Right.
dermabond glue. But there is a small percentage, and we don't really know why, you know, who have an allergic reaction to that, or, you know, something doesn't sit well with them. So trying to suss out who that is and make sure that you're, you know, doing the right operation for the right patient is important. And I think it is important that they look and make sure there's nothing else. You would hate to take someone's implants out and miss, you know, some other undiagnosed condition because of that. So that's real important too.
Right, absolutely. And I know there are a lot of online communities talking about breast implant illness, and there are a lot of surgeons who really do have a niche. And many of them recommend total en bloc capsulectomy, where the entire capsule is removed. And really, I think they generally recommend to not violate the capsule at all so that it stays contained. Scientifically, though, we know there's not really a lot of data behind that.
That's right.
Yeah. I mean, what do you try to do normally with your patients?
So I try to meet in the middle, which is to do as much. So I give the patients choices, and I talk to them about science, and that there is no science that shows that doing an en bloc is is better than doing a total capsulectomy or doing a partial capsulectomy. But if there's some controversy about what incision you use for breast surgery, for breast augmentation, and I tell people what the pros and cons are and help them decide, maybe what's best for them. So the trade-off of doing an en bloc removal is that the incision is pretty big, because to take the capsule and the implant out as a whole, it doesn't compress at all. And so you need a big space. So if you come, say, I want my implants out, I don't feel great, I just want them out. Can you go through my incision that's just around my areola, that's, a couple centimeters? Yeah, I can do that. Can I get the entire implant and the capsule all out through that incision? No, it's not possible. So that's like one of the trade-offs. And then, if you're like, okay, well, I'd rather have you do it through a smaller incision, then I say, great, I can get around the capsule and the implant, then make a small incision in the capsule, take the implant out, and then take the rest of the capsule out, wash everything, and that should be equivalent science. I mean, en bloc is usually, the term, as you know, comes from cancer surgery, right? The en bloc, removing everything that's surrounding the tumor and not touching the tumor. But
right. And I think the other part of this that's not often talked about is the fact that this can be kind of damaging, especially, if the implant's behind the muscle, that posterior capsule is on the ribs, and it's really tightly adherent to the ribs, to the periosteum, to the muscles between the ribs. And getting that off can be very damaging. In most patients, if their implant's behind the muscle, I recommend leaving it in place. I mean, after all, as you mentioned, this isn't a cancer surgery, and I certainly don't want to injure somebody's lungs. So I take off what I can, and I can cauterize the rest. Right. But often it's, how much damage you want to do when the benefit's not really well proven.
Right. And even in cancer operations, there's sometimes like no man's land where you can't go further. So you have to weigh the risks and benefits of, being in a major vessel or just taking the, tumor right off. So yeah, I explained to my patients that's not always possible. I tried some techniques though, to try and get that capsule off the that posterior chest wall, because you can hydrodissect it, different tools. But I do tell them that I'm not going to do something that's unsafe. And there have been documented cases where people have had, dropped lung or gotten into a blood vessel because it goes way up into the chest and you're trying to get that last little bit of capsule. So I think that risk reward isn't worth it.
Right. It's the whole field of breast implant illness is really tough, because it's this big group of women who are definitely not feeling well, and to a certain extent have felt like they're being blown off by some of the medical community. And then there's niche of doctors, I'm sorry to say, who some of them maybe take a little bit advantage and make these recommendations for things that aren't necessarily proven with good evidence behind them, and say, well, this is the way you have to do it. And it's hard because you're in this balance of, you want to take good care of people and you also don't want to see them taken advantage of because they're not feeling well and they want to do anything they can to feel better.
Yeah, absolutely. So I think it's a tough spot for the majority of us. I think having that community of women with breast implant illness has raised awareness. And, I agree. And early on, they were ignored or, sort of dismissed by many surgeons who told them, no, that's not, and I think it's your implants. You elected to put them in. It's your choice to remove them. So as long as I can educate you about the circumstances surrounding it and what the results will potentially look like, then we can have that conversation. But dismiss somebody outright, which definitely happened early on and probably still happens here and there. But yeah, I'm not trying to sell this as this will make you feel amazing get your implants out, which is kind of the shtick people have. But everyone to their own. And I know Dr. McGuire has a grant that she's doing where she's carefully studying these patients and and kind of doing all the intake stuff and testing everything. And I think that's important too, so that we can have some, more hard science to back up what we're doing and make some smart judgments.
Right. I mean, it reminds me a lot of fibromyalgia in the early days. People
Mm-hmm.
kind of off, and now that we actually have diagnostic criteria, we have a good idea of what the effective treatments are instead of just kind of saying it's all in your head. So I think definitely
Right.
is the way to go. But I would like patients to know there are really sympathetic surgeons out there who are willing to listen and want to make sure we offer safe choices that aren't going to do more harm than good.
Right. And I think it does have to be kind of an education, because the biggest question often is, what is it going to look like when you take the implants out? And
Right.
it can be a change, and there's so many things to consider. And so I tell patients there's one of the biggest factors is the implant to breast tissue ratio. So how much implant you have in there and how much breast tissue you have. And what, if you were a double A and you have an 800cc implant, that's when I take that out, that is a very different problem than a 200cc implant and B or C cup breast now. I mean, it's two different situations. And so having a lot of like before and afters and talking to them about what their goals are. Some people just want them out and want to feel better, and then kind of come back and reassess. Maybe they want to change the shape or the volume. So I think those are all things to consider.
Right. And there are always options down the road. Sometimes we do a lift at the same time. Sometimes if there's not a lot of breast tissue, we worry about the blood supply and we want to wait. Fat grafting is also an option that can be done at the same time or down the road. So there are a lot of variables with breast surgery in general. And I'm a little biased, but I kind of feel like women have a bit of an advantage understanding the benefits, what things are going to look like, and what the goal is.
Yeah, I agree. And I think it's great because you made a great point. It's not like you can always come back and do a lift or do fat transfer. So if you want to just focus on having the implants removed, that's totally an option. And don't panic because you haven't burned any bridges by doing that. And so
Exactly.
and just be with you along the road to recover, and then you can make some changes. And I've had some women who are like, okay, I'm planning to have a kid, so it seems silly to take them out, do a lift, and then come back around for another one. So absolutely, those are all things to factor in.
Right. And, for women who are considering getting implants, I think it's good to know that breast implant illness is out there, that it's something that you're going to hear discussed. But like Kat said, it's not something I would really consider high risk. We don't know exactly how many women have it or what the diagnostic criteria are. But when you look at the millions and millions of women in the world who have implants, it's a pretty small fraction.
Right. And so it's a risk, just like, there's a risk of capsular contracture, a risk of having a problem, or risk of rupture. And I do think, again, early on when implants were first being put in, there wasn't a lot of discussion about what the long-term, I remember having that conversation as a trainee where the nurse is like, what do you mean they don't last forever? And I have these.
I've still had patients come in who've had implants for 40 years and they're like, wait, these don't stay in till I die? No, they don't. And now that's like straight up first thing on the consent form. These do not last your lifetime. You will need them removed or replaced.
Right. Yeah. So all of that, I think, again, it's all about educating the patient. I feel like my dog is very uninterested in our conversation.
Mine is being good. He was rummaging through a bin of Legos right before we got on, and it was so loud.
Why? What's in the Legos?
He just likes to chew them. And then immediately after that, my husband's waiting for me to talk about him. My husband starts rummaging like in the cupboards through the bags of food. I was like, why are the boys just all rummaging? It was so loud. Oh, I see we have some comments. Somebody had capsular contracture and replaced her implants and would have just explanted them instead. Yeah, and that's another complex conversation when people have capsular contracture, which is the scar tissue around the implant getting firm. You have the option to replace, you have the option to remove, you have the option to fat graft. There are a lot of nuances, and these are patients I spend a lot of time with in the office discussing the options.
Yeah, I'm currently working with somebody now that has capsular contracture. She had her primary augmentation done elsewhere, and we are sort of mired in what to do.
Yeah.
Oh, and one of the things about capsular contracture is that we don't know a lot about it. Like chalk that up to breast implant. But oftentimes it just happens in one breast. So
yeah, and
whatever
then
happened,
just don't look the same.
right? And so you're not sure. So there were replacement was my only option then. Yeah, it's a bummer. But I think people are more educated now and know, because sometimes you can keep having capsular contracture, and then what do you do? And that can be a really tough road. So having the option to say, okay, you can do this. These are the odds that you're going to have capsular contracture again. These are the things that can contribute to it. And maybe you want to get off that implant train now and cut your losses. That's an option too. But it is hard. There are a lot of options with capsular contracture once you start having that problem. Sometimes though it's easy, like smoking is a known cause of capsular contracture. So I won't redo someone's breast implants for CapCon if they're actively smoking, because it's kind of a waste of time.
Right. Right.
But
And we all know, we want to minimize bacterial contamination. We all use antibacterial solution and betadine, and some of us use Iricept and all sorts of things to rinse out the pocket. I think most of us also do Singulair and vitamin E post-op if you've had a CapCon, but it can be very frustrating. So Holly,
yeah.
I'm sorry that you went through that.
Yes. And then most of us, are you using the Keller funnel to put
Yes. Yep, I use a Keller funnel in every implant except when it was briefly on back order. And that too, if you guys haven't seen it, it's amazing. I think I have a video back in my Instagram feed. It looks like this big pastry bag, but it's got this special like hydrophilic lubrication on the inside. And you put the implant in and just squeeze it right through the incision. And it doesn't touch the skin, so it doesn't get bacterial contamination from the skin flora. It also, I don't know about you, Kat, my hands are not big. And I remember in residency, like trying to get the implant in with my tiny hands, and it would like pop out. So they also make our lives much, much easier.
Yeah, I think I've explained that. That's how I explained it. I was like, the Keller funnel was the best thing ever, because my little fingers you're trying to work this implant in, and it was just a struggle. And now it's just squeezed, doesn't touch the skin. It's awesome. Wish I thought of it.
I know that, and the back dressing. That was
Yes, I just put a wound back dressing on. That was my second case today.
I know those. I remember I interviewed at where was it? Who invented the vac? I can't even think of it. But the chairman there had invented it, and he had his name on the patent. It was very cool.
Oh, really?
Mm-hmm.
Sort of like the anesthesiologist who invented the bear hugger, the thing that keeps patients warm.
He probably owns an island somewhere. I bet.
Yeah, right.
Wow, we have already gone on our 20 minutes. I mean,
okay.
Help, but we covered a lot today. Breast implant illness is pretty complicated.
Yes, I agree. So yeah, we'll take suggestions. Just DM us if you want to hear a different topic. And if not, we'll meet up in 2 weeks. I'm sure we'll have something to talk about.
Absolutely. And we do alternate who hosts. So next time we'll be on your Instagram feed, but I'll make sure to post it so you guys know where to search and find us.
All right. Bye, everybody. Thanks for joining.
Bye. So good to see you.
It was good to see you. Have a good week.
You too.